Good evening, everyone. I'm Debbie Hilbasell. Tonight we are going to do case list reviews, and it is November 1st. So we've got the first testing group out of the way in October, and then we've got the two groups testing this month. So anyway, tonight what we're going to do is case list review. And I didn't change the date on this. Sorry, this was the last time I did it, but it is not Thursday, September 29th. I actually am oriented to place and time. It is Tuesday, November 1st. So my apologies there. Anyway, so let's just quickly, there might be some people who are new on the webinar since this is November 1st, but with regards to how you participate, there's a little orange arrow right here up in the upper right hand corner of your computer screen, and what that does is it simply opens and closes your panel in case you need to see a full screen view. It looks like the vast majority of you, or it looks like actually everybody, is on using their mic and speakers from their computer, and so there's nothing that you need to do except use them. But if you chose to phone in, if you click that, you'll get a phone number, an access code, and a PIN. The main thing that I'll be asking today is, of course, when I ask for volunteers, you'll raise your hand if you want to volunteer. In addition to that, be thinking about, before I even call on you, if you have a particular case you would like to be questioned on, tell me that when I call on you. If you have a particular case list you would like to do, please raise your hand, or when I call on you, tell me, I'd like to do office or I'd like to do GYN. The other thing is, when I do call on you, if you look up underneath the little orange arrow, there's a little microphone underneath. You're going to be muted on your end. I unmute you so that you can talk, but if for some reason you aren't able to, I can't hear you, make sure your microphone is green. And then with regards to calling on people, I know we're starting fresh in November, but I have a list of all the people who were called on in October and know how many people were called on 2 times, 3 times, 4 times, etc. And of course, our goal is to allow those people who haven't had an opportunity to go yet to be called on. And so when I'm going to give you guys a little clinical pearls. I call it kind of my little mini lecture that I always do before I start the case list. But when we start, I'm going to ask for volunteers who have not gone at all, like say that you weren't called on at all in the month of October. All right, so now let's look at I cannot get this stupid thing off here. All right, I actually just did. There you go. So I was not able to get it off. All right, so let's talk about some hormone therapy pearls. I do a lot of mock orals, also the one-on-ones in addition to the lectures. And the one thing repetitively I find that the candidates struggle with is, how do you counsel patients about hormone replacement therapy? And where people seem to get lost the most is with regards to talking to them about the risks. So let's sit back for a few minutes and let me go over this. So after the WHI came out in 2002, the prescriptions for hormone therapy decreased precipitously, primarily because that study was ended before it was completed for the risk of cardiovascular disease and the risk of breast cancer. Since that time, we have well over 18 years of post-intervention analysis of the WHI, as well as some other studies that have looked at hormone therapy. One is the KEEPS, and the other one is the ELITE, it's like early hormone replacement therapy, that looked at not waiting until patients were in their 60s to start people on hormone therapy. And the bottom line is, when you look at all the data that we've had since that initial WHI, we can say overwhelmingly that there is a favorable safety profile for healthy women to start hormone therapy early in menopause. So if you have a patient who's less than 60 years of age, she's with and or within 10 years from her last menses and she's healthy, the benefits outweigh the risks for starting hormone therapy on those patients. The type and the route of hormones matter. And we'll talk about the different type of progestins in a minute. But transdermal estrogen, when they look at even the studies, there was one study that showed that transdermal estrogen actually had less VTE risk than even placebo. But the bottom line is we can pretty much negate the VTE risk by giving patients transdermal estrogen. It avoids that first pass hepatic metabolism, and because of that, you don't get the increased risk of you don't get the increased production of coagulation factors. So not only is transdermal estrogen estradiol, it's not a synthetic estrogen like conjugated equine estrogens. We get rid of basically the VTE risk. So if we look at that again, the WHI was stopped due to the increased cardiovascular disease risk in breast cancer. And so now they've looked back and said, okay, so if we can make a blanket statement that for the healthy women that are less than 60 and less than 10 years postmenopausal, benefits outweigh the risk. Great, and we can treat their symptoms. But what about heart disease? And that's the risk of heart disease with hormone therapy is a little bit more complex. Again, what hormone therapy actually reduces cardiovascular disease if started in healthy women less than 60 years of age and less than 10 years postmenopausal. So ACOG, NAMS, the Endocrine Society supports starting hormone therapy in these women if they're symptomatic, and obviously if they're healthy, they don't have contraindications, right? If they're greater than 60 or more than 10 years from their last menses, the benefits and the risk are less known. So with regards to cardiovascular disease, they do recommend we do a risk stratification, and actually you can calculate the Framingham risk score, or the North American Menopause Society, NAMS, actually has a really awesome phone app you can put on your phone where you can calculate the patient's cardiovascular risk. So if you calculate the patient's cardiovascular risk and it's low, it's less than 5%, then they can use either oral or transdermal estrogen. If they have a moderate cardiovascular risk in the 5 to 10% range, transdermal is preferred. And if they have a high risk, then hormone therapy is not recommended. What about breast cancer? Again, the risk is largely dependent on the route in the formulation of hormone therapy. So we know from the WHI that oral estrogen plus the progestogen increased the risk of breast cancer, but it was a very rare increased risk. So the WHI showed that there was one additional breast cancer case per 1,000 person years of use. So basically for every 1,000 people who took hormones, there was one additional case if you took estrogen plus the medroxyprogesterone acetate. To put that in perspective, that risk is less than if your patient drinks 2 4-ounce glasses of wine a day, and that should be wine, not wins. I typed this up today, I forgot the E. The risk is similar to as if you're obese and or you have a sedentary lifestyle. So that really helps to put it in perspective. And estrogen alone has not been shown to increase the breast cancer risk. And some of the newer studies too have really felt it's that medroxyprogesterone acetate, the synthetic progestins, that are more associated with breast cancer, whereas the oral micronized progesterone has much less adverse impact on breast. So what should we do to look at a patient's risk of breast cancer? So if they have average to moderate risk of breast cancer based on the Gale model or the IBIS tool, they can take hormones. Now, so high risk, so that would be somebody who has a greater than 5% 5-year risk of breast cancer or greater than 20% lifetime risk. They should consider non-hormonal options for their vasomotor symptoms. Obviously, patients who have a history of breast cancer shouldn't be prescribed hormone therapy, and vaginal estrogen is okay in our breast cancer patients if cleared by the medical oncologist. All right, what are some of the other health benefits of hormone replacement therapy? Well, you get improved bone health, you get reduction of fractures, you get reduction of type 2 diabetes, you get improved insulin sensitivity, improved lipid profiles with increased HDLs and decreased LDLs, and you get reduction of colon cancer risk. Again, if we look at those healthy women that start hormones less than 60 years of age and less than 10-year postmenopausal, it has been shown to reduce all-cause mortality. And again, with the risk of stroke and VTE, low risk, this should, I was so tired when I typed this. You have a low risk when using transdermal formulation. So I'm sorry, that should not say oral, so please fix that. What an idiot. Okay, sorry. Anyway, what about obesity? If somebody's obese, they really recommend you prescribe transdermal because we do know obesity in and of itself can increase VTE risk. So prescribe transdermal. Here's what's interesting. Estrogen does preserve lean body mass and it does reduce visceral adiposity, which is good. But obesity in itself increases the risk of cardiovascular disease, VTE, and certain hormone-sensitive cancers. So obese patient who's symptomatic, and obese patients actually have higher rates of symptomatic vasomotor symptoms than lean patients, and you wouldn't think that, but they would benefit from transdermal. And then if they have hypertension, again, you should use transdermal estrogen, and it's really recommended if the type of progestin matters with hypertension. You should use the micronized progesterone or even drospirenone because they are both actually either beneficial or neutral for blood pressure control, whereas the synthetic progestins like medroxyprogesterone acetate can actually cause elevation of blood pressure, and oral estrogen can cause vasoconstriction and or increase sodium retention and increase blood pressure. So hypertension is transdermal estrogen and micronized progesterone or drospirenone. All right, contraindications. Okay, contraindications for oral or transdermal estrogen-based therapies include, now these contraindications do not apply to vaginal estrogen therapy because the serum estrogens are so low. So known, suspected, or history of breast cancer, any other known or suspected history of estrogen-based cancers, uterine cancers, etc. Women who've had a hysterectomy and have no remaining evidence of disease are still candidates for hormone therapy. That's with endometrial cancer. Active DVT or history of DVT or PE, history of a blood clotting disorder with the most common being factor V latent mutation. Anybody who has had arterial thrombotic disease, such as a myocardial infarction or a stroke, chronic liver disease or dysfunction, or migraine with aura. The one thing that I ran out of time before the webinar tonight was to talk about dosing. So we're supposed to start with the lowest dose that we think might be effective. And so a good example would be to start with transdermal estrogen, a 0.025 milligram per day or a 0.0375, and then give 100 milligrams of oral micronized progesterone at bedtime. That would be a good starting dose. If the patient really didn't want a transdermal patch, they just wanted oral, then starting with like a 0.5 milligram of estradiol would be a good starting point. You can always go up if you need to. So those are your clinical pearls, and then just make sure that you don't say that there's the low risk of stroke and VTE with oral because it's the opposite, it's the transdermal. So that's my goof up. Okay, so let's go ahead. Anybody who has not been called on at all during the month of October, if you would like to volunteer, go ahead and raise your hand. And we're going to do case list review, so let me know if you have a particular case or a case list that you would like to go over. Let's get Jared. So there you go.
Hello.
Hey, Jared, how you doing?
I'm good. How are you doing?
Well, obviously I'm overtired because I was like, oh, I got to quick type up my little pearls before I start the thing. And I guess I wasn't as on the ball as I thought I was. All right. So are you a generalist or a subspecialist?
I'm a generalist.
All right. And so do you have a particular case or case list you would like me to question you on?
Let's just do GYN and anything you see that I guess may give me problems, whatever you think.
All right. Sounds good. And when do you test, Jared?
December.
Okay. All right. So you do quite a bit. You do your own your own TVTs, huh?
Yes, ma'am.
All right. All right. Let's do patient 7. 36-year-old G1P1. She must have presented with pelvic pain or something, and the ultrasound showed a 5-centimeter teratoma of the right ovary and a 2-centimeter on the left. What's interesting of her prior surgical history is she's had a hernia repair without mesh and a cesarean. Where was the hernia? Was it umbilical or inguinal?
It was umbilical. Yes, ma'am.
Okay, so you want to attempt to, well, first of all, why do you even have to do surgery on her? If she was asymptomatic, tell me what you would offer her for options.
Certainly at 5 centimeters for a dermoid, it certainly becomes a little bit, if they're asymptomatic, I think borderline. If they are asymptomatic, you could, I guess, still watch them, but when they get over 5 centimeters, they have a higher risk of torsion, especially with dermoids that tend to be heavier cysts. So they have a relatively, I guess, comparatively higher rate of torsion. So at 5 centimeters, I do offer surgical resection, even if they're not really symptomatic.
Okay, if she had two centimeter ones, would you be more comfortable observing those?
Yes, ma'am.
Okay, all right. So now she's got one that you are right is at that size that it could just torse at any point in time. So now you talk to her about going in and resecting, doing bilateral cystectomies. But now you know she has the potential of adhesions and she's had an umbilical hernia repair. So how are you going to enter her peritoneal cavity?
I tend to use the Very's needle. I do tend to kind of use, I guess, what's called Lee Hung's point, which is just anything super umbilical. So, or Palmer's point in the left upper quadrant. It really just kind of depends. I don't remember which way I did this one. I think because I knew that she had no mesh kind of the op report, I think I just went kind of halfway between the umbilicus and the xiphoid. I think is where I actually went, and had
Okay.
them had anesthesia place an OG tube for me to decompress the stomach.
Okay. And so then once you got in, you did say you had to do some lysis of adhesions. What did you actually see?
I think in this case, she did have some omental scarring down kind of at the kind of the bottom that was obscuring my view. So I think I took some of those down. I don't think there was anything really stuck to the ovaries. I think it was primarily just omental adhesions down into the pelvis.
Okay. And so then with regards to the cystectomies, were you able to do the bilateral cystectomies without any spillage of peritoneal contents?
I was able to get both of these out. I did warn her the 2 centimeter one because it looked like it was somewhat deep. Just looking at the ultrasound, I told her that I would try to take the 2 centimeter one out. I'd kind of counsel her like, there's always a chance I can't find it, depending. In this case, obviously, I think that the pathology showed that she had a hemorrhagic corpus luteum on the left, is what the pathology showed. So I had to follow her ultrasounds afterwards, and it's been stable. But in this case, I did get both of them out without spillage because I certainly wasn't 100% sure on the left cyst. And when I took it out, it didn't look like a dermoid. Looking at it outside of her abdomen, but I didn't want to dig around her ovary to lower her ovarian reserve too much.
So when you took that, excuse me, the 2 centimeter cyst out, so is there still a teratoma in her ovary, or was that really what it was? It was a corpus luteum.
There was a second dermoid that was in there that was, after I re-imaged her, told her, hey, pathology in the left one, I couldn't get the left dermoid out. I re-imaged her. It was still there. I think I did this case close at this point a year ago. I actually saw her recently. I think her last ultrasound was about 3 months ago, and it's been about 2.2 centimeters, something. It's been unchanged. So we're just essentially following it for now.
Perfect. Okay, because bilateral teratomas aren't that unusual. Do you know what percentage of the time teratomas can actually be bilateral?
I think it's 10%.
It's actually like 15 to 20% even. It's
Okay.
even higher than that. The bottom line is if you've got one on one side, look very closely at the other ovary because there could be a small one. All right, so now what would have happened if you were resecting the teratoma and you actually did, have spillage of the contents into the peritoneal cavity? Why is that even a big deal, and how would you manage it?
Usually I would just irrigate them really copiously. I'll make sure I try to get as much of the contents as I can. They can get a peritonitis afterwards. There is spillage, so that's the main thing I worry about, is just trying to irrigate really good copiously and make sure I get all the material out.
Okay. I'm trying to think what else we could ask. When would you actually remove the entire ovary for a teratoma? What would force your hand to do that?
Certainly, probably in a patient that I believe that if they're over 45, usually it's generally recommended, essentially in all cases, to remove. I usually, if it's a really large one and it's replaced all the ovary, I recommend it. And then obviously, if they've completed childbearing too, you can also counsel them and consider removing it as well.
So let's just go back to that. What if this patient was 36G1P1, had a tubal ligation, and you really could see normal ovarian tissue? So you had the option of, I think I can resect this and have some normal ovary left, or she's already had her tubes tied, I'm just going to take out her ovary. What would you do and why?
I would probably still err towards the side of trying to do a cystectomy if I could, especially if I thought that I could do it with, a very low risk of spillage. And mainly just because, honestly, just to keep her ovarian reserve up. She had tubal. I'm not too worried about her fertility. But like I said, if she ends up getting, we'll say, a large one on the left side at some point, and then I have to go take her left ovary out, then I've kind of put her into menopause at that point. So if I've taken the other one out before, so I would tend to save her ovary if I could.
Good. Yeah. Good. Because I'm going to just kind of tease you. If I thought that way about your testicles, you probably wouldn't be too happy. Good grief. You had a vasectomy. Just get rid of one of the testicles. Who cares? Okay. I'm giving you a hard time, Jared. Okay. I got to help you guys laugh through this process because otherwise you're going to all be crying, right? But no, the bottom line is you're right. If you go in and there is absolutely no normal ovarian tissue, sometimes you absolutely just have to. Obviously, you feel less bad if somebody's 45, 48, closer to menopause. But in somebody who is only 36, I think you really should try to save that ovary, even if they've had a tubal ligation, just because you said they can be bilateral, something could happen on the other side, and then you've got a young woman who has surgical menopause and with all the inherent adverse effects that come with that. So good job of how you entered and all that type of stuff. Any questions for me, Jared?
I don't think so. Thank you very much.
Okay, thank you. Let's get Lindsay, and I'll go out of here. Hey, Lindsay.
Hi, good evening. How are you?
How are you? And are you a generalist?
I'm a urogynecology fellow.
Okay, so how about OB?
That would be awesome. Yes, please. Thank you.
All right, let me go toward the back here and see if there's
Okay.
something we could do. And you're like, why do I even have to be tested on this?
Spend some time for OB, so this would be great. Thank you.
Mm-hmm. All right, this number 15 has got all kinds of good stuff in it. All right, so you have a 26-year-old G1P0 who was diagnosed with gestational diabetes and actually did require pharmacotherapy to control her blood sugars. And so she was on insulin for her GDMA2. Why is
Mhm.
insulin the preferred agent over the oral agents such as metformin or glyburide?
Sure. So, insulin is the preferred agent in gestational diabetes because of the ability to control the patient's blood sugars, which can greatly impact the fetus. And there's been most of the studies have been performed with insulin.
Yeah, so you get much better, much tighter control, but do you know of any other reasons why insulin might be preferred?
It does not cross the placenta.
Yeah, and that's huge. We really don't know long term what is going to be the impact of these fetuses who have been exposed to metformin. We really shouldn't even be using glyburide anymore, but it does cross the placenta, so who knows how it's going to long term affect their pancreas, etc. All right, so we get better control of that. Okay, now how do you counsel patients once they develop gestational diabetes? Or of what are some risks that can be associated with gestational diabetes and pregnancy?
Sure. So some of the risks that can impact a pregnancy in terms of gestational diabetes. I like to think of this in terms of maternal and fetal complications. So in terms of maternal complications, it can increase the patient's risk for cesarean delivery, increase the patient's rate of a failed induction, going alongside with that, increase the patient's risk of developing preeclampsia or hypertensive disorder of pregnancy. Um, it can impact the delivery itself with increased rate of shoulder dystocia and complications with the delivery. In terms of fetal complications, there can be some congenital anomalies, specifically cardiac defects. There can also be brachial plexus injury as a result of a shoulder dystocia,
So
large for
oh,
gestational age
sorry.
or even small. Oh, I'm sorry.
Why would gestational diabetes increase congenital anomalies and cardiac defects?
Um, You know what? I think I missed both. I think I want to take that back. That would be more for pre-gestational diabetes.
Yeah, because typically, when do we actually even make the diagnosis of gestational diabetes?
Yeah, so typically not until 28 weeks. So that would be more congenital anomalies would be more of a concern with pre-gestational diabetes when the exposure to the high levels of glucose is starting at, during embryogenesis.
Perfect. Okay, good. Yeah, so then, so now,
Mhm.
yeah, so now we know we can have problems with growth, and usually the babies can, especially with the degree of control, the babies can be big. And you did suspect macrosomia. She was only 38 and 2. So,
Mhm.
at what estimated fetal weight, because you did offer this patient a C-section, at what estimated fetal weight is it recommended we should at least offer a C-section to somebody with diabetes or gestational diabetes?
Yeah, so that would be at 4,500 grams for a patient with diabetes in
I know.
pregnancy.
Seriously, your case almost looks fake because it was it was exactly 4,500. It's like, okay, who fudged the weight?
So her
Anyway,
suspected, if I recall, her suspected was about 4,800. But yeah, the actual fetal weight was
that's
4,500 on the
hilarious.
nose.
And because we recommend if they're not gestational diabetic, we say 5,000 grams. Why do we use a lower weight for somebody with diabetes to try to reduce the risk of shoulder dystocia and brachial plexus injury?
Yeah. So with patients who have gestational diabetes, the concern is for the distribution of the fat in the fetus being more truncal, which can lead to increased risk of shoulder dystocia as a result.
Okay, so was the so anyway, with the thought of macrosomia, why was the recommended C-section at 38 and 2 versus just wait to 39 weeks? You weren't going to let her deliver vaginally anyway.
Right. So that was given the diagnosis of the gestational diabetes and the fact that that she required medication. So when we were counseling her and discussing, um, you know, given that the fact that with the gestational diabetes, a little bit of an earlier time frame was decided in conjunction with maternal fetal medicine for this patient.
And when did you actually diagnose her with preeclampsia with severe features?
Yeah, so that was actually diagnosed when the patient was in the recovery room after her C-section. So when she came in for her scheduled C-section, her blood pressures were okay, but it wasn't until after the C-section when she started to have elevated blood pressures. I believe for her it was as high as like 180s systolic, recurrent in the recovery room.
Wow, so her severe features were the severe range blood pressures. What are some other features that would make preeclampsia severe?
Yeah, so some of the other features would be looking at lab abnormalities, so specifically platelets. So platelet count less than 100,000, elevated or abnormal liver function tests, so that being the AST or ALT 2 times the upper limit of normal. Could also look at the creatinine, so creatinine greater than 1.1 or 2 times the patient's normal. Any neurologic features such as visual changes or persistent headache unrelated with medication.
All right, so then let's see here. So we did the preeclampsia severe. Oh, now let's go back to the gestational diabetes. So what do you need to do postpartum on this patient?
Yeah. So for this patient postpartum, after her C-section, I would want to monitor her blood sugars while she's in the hospital. For gestational diabetes, after delivery, we would suspect this would get better, but this patient is at risk of developing long-term diabetes. So I would want to have her follow up and repeat testing around 6 weeks postpartum to see if she is at risk of this being more of a long-standing issue that could be outside of the pregnancy.
Okay, great. So I can't think of anything else. I mean, when her blood pressures went up, are you comfortable, Lindsay, walking through the antihypertensive, like what you would give? Do you
Yeah,
want to
the
just,
protocol. Yeah,
yeah, okay.
yeah.
Why don't you just quickly go through it for everybody? It's a good review for everyone.
Sure, sure. So on presentation for this patient, as I said, since she was in the recovery room after her C-section, she did have IV lines established. So in that situation, I would start with labetalol 20 milligrams IV. And that would be something that would be pushed over a 2-minute time period. I would repeat the blood pressure 10 minutes later. If the blood pressure remained elevated, then at that point, I would administer labetalol 40 milligrams IV push in the same fashion, repeating it. And again, if still elevated, I would move to labetalol 80 milligrams, and I would repeat the 80 milligrams a second time if need be, if still elevated after that 10-minute. At that point, then I would kind of have maxed out in terms of my labetalol, and I would move to another agent. I could consider nifedipine or, oh gosh, I'm trying to complete blank. Nifedipine or I might need to
Starts
count
with
last
a
week.
H. Starts with a H.
Hydralazine, thank you. And I would then move through the algorithms with that in terms of the remainder of the protocol. If I switch to the hydralazine, my starting dose could be 5 or 10 milligrams. And that would also be an IV push over 2 minutes. And the repeat for hydralazine, I believe, is 20 minutes.
Okay, good. All right, great. So then what would you do for her in a subsequent pregnancy? She's had gestational diabetes, that GDMA2, and she's had preeclampsia with severe features. So what are you going to
Yeah.
do talk to her about at her new OB visit?
Definitely. So I would want to counsel her about the increased risk of this pregnancy given her prior history. So for her in particular, with a history of gestational diabetes requiring insulin, I would discuss with her recommendation to perform an early glucose tolerance test in order to diagnose this potentially earlier if she wasn't diagnosed with pre-gestational diabetes outside of the pregnancy. I would discuss with her aneuploidy screening, which I do with all of my patients. In particular, my practice generally is the cell-free DNA and the nuchal translucency. And I would, of course, offer her diagnostic testing as well if she desired. In terms of the history of preeclampsia with severe features, also with the history of the gestational diabetes, she would meet criteria to begin low-dose aspirin as a preventative for preeclampsia. So I would make sure that she's starting low-dose aspirin of 81 milligrams, starting between 12 to 16 weeks, but definitely by 16 weeks of gestation.
Perfect. You walked through that really nicely. So good job, Lindsay. Do you have any questions for me?
No, I don't. I really appreciate the time. Thank you so much.
Okay. Uh-huh. All right. So anybody else would like to go? So, okay. So let's see here. Let me lower hands. Let's see. All right. So let's see here. So now I don't care if you went in October or not. So anybody else who would like to have an opportunity to do a case list. All right. Now let's get Brittany. Hey, Brittany.
Hello.
I was trying to get
Good
those
evening.
other people to volunteer, and man, they weren't having it, were they? All right, let me find you. Okay, you're a generalist, right?
Yes, ma'am.
All righty, you tell me what case list or whatever you'd like to do.
Let's do either GYN or office.
We haven't done an office yet, although you did get a hormone lecture, so there you go.
I don't think I actually have hormone replacement on my list, so.
Well, good. I'm not going to ask you about it. I think you guys got enough of that already. So let's see here. All right, this is a good one. Let's look at patient number 9. 32-year-old G0P0 comes in, primary infertility, and you also get a history of tobacco use. So before I actually talk to you about the infertility workup, let's talk about tobacco use. How do you counsel patients about the impact of tobacco with fertility and even pregnancy, should they conceive?
Yeah, so I talk to all my patients, GYN or OB, just about if they use tobacco products, and if so, whether it's cigarettes or even like vape products. If they say yes to that question, I'll usually talk to them about if they have any interest in quitting, if they've thought about quitting. I will recommend that they quit, kind of whether or not they say that they've thought about it or not. If they seem interested or say that they are interested in quitting after we talk about it, then I'll give them some various options about how to assist them in tobacco cessation, specifically non-medical or medical options. And then if they take that up, then I'll follow up with them typically in 4 to 6 weeks about that process.
Okay, so now let's talk about actual effect. What does smoking do? Any kind of tobacco use? How does that affect conception? So like how does it interfere with fertility?
Yeah, so for patients who are trying to get pregnant, it can impact, it can be part of like a decreased ovarian function. So it can contribute to early menopause. If patients then even were to achieve an early pregnancy, it can increase the risk of miscarriage. So those are kind of for early pregnancy, the two main things that I counsel patients about.
And then what about if they conceived, made it through the first trimester? Tell me how you would counsel them about risks in pregnancy.
Yeah, I counsel patients that they're at an increased risk of preterm delivery, of small for gestational age or IUGR, of placental issues, including abruption or placenta previa, are some of the main risk factors that I think about.
Okay, so now let's talk about primary infertility. So she comes in, her and her partner have been trying over a year to conceive. Walk me through the different causes of infertility that you discuss with her and tell me how you're going to evaluate those causes.
So I explained to this patient that for her infertility, which, yeah, they had been trying to conceive for greater than 1 year, that about a third of the time it's male factor or semen related. About a third of the time it could be female related, whether that's tubal factor, something wrong with her uterus, such as a submucosal fibroid or structural problem, cervical factor. Or some hormonal issue, whether it's a thyroid disorder, diabetes. And then a third of the time, it could be both things. So both a male factor and a female factor. So that's kind of my general discussion. And then I focus in on her evaluation, which I got into a little bit in regards to how we're going to evaluate her fallopian tubes, depending on her risk factors, what kind of laboratory studies we would initially get, and then any sort of imaging, like specifically an ultrasound to assess her anatomy if that had not been prior done. And then, of course, just a basic physical exam and further history while she's there.
Okay, so let's say it sounds like she was having regular menstrual cycles, and so you confirmed ovulation with a day 21 progesterone. Good, check on that. You did a HSG that was normal, showed normal bilateral tubal patency, no obvious endometrial cavity abnormalities. But let's talk about the HSG. When in the cycle should you do that and why?
We do HSGs in the follicular phase so as not to disrupt an early pregnancy in the luteal phase.
Perfect. And then do you typically give doxycycline for prophylaxis before HSG?
Yeah, so I guess I should clarify when I say we. I actually do not have an HSG machine in my office, so I do refer patients to a reproductive endocrinology office for an HSG. The one that we refer to does provide doxycycline prophylactically, but I personally do not perform HSGs.
Okay, I'm going to go out of exam mode for a minute. That's pretty interesting because that they're starting to do that more and more. I know even some of the radiologists that do it are starting to give doxycycline prophylactically. Because prior to that, what ACOG has said is if somebody's had a history of PID in the past, you should prophylax with doxycycline. And of course, if you did an HSG and you saw bilateral hydrosalpinges, then you should treat with doxycycline for like 5 days. But I am hearing more and more people now just routinely prophylaxing with doxycycline. So that's interesting that that's what your REI does. Okay, good. So then HSG is good. She's ovulating. Tell me what preconceptual lab studies you did, because you said they were normal. What are you going to do routinely for blood work on her?
So for this patient, I got a TSH, a prolactin, an A1C, a rubella and varicella titers. I did end up getting a hepatitis C antibody after talking with her about the risks or benefits of doing that. She had not been screened prior. And then ultimately, given that I referred her to REI, I did get an AMH kind of in preparation of that referral. And then the day 21 progesterone was specifically on day 21.
Okay, and so then all her stuff was fine, but the semen analysis was low, so you sent to REI for them to do whatever they're going to do, right?
Correct, and counseled her that they would probably talk with her potentially about intrauterine insemination and repeating the semen analysis potentially, but in the process of that, I did refer them, yes.
Perfect. Yep. And I think you did a great job. The only thing I would add in addition with the smoking is for some, we think it's the smoking, the effect on the cilia in the fallopian tubes. They do have increased risk of an ectopic. And
Okay.
then also PPROM, for some
Okay.
reason, have increased risk of that too. But great job, Brittany.
Thank
Any
you so
questions
much.
for me? Okay, thanks.
No, ma'am, thanks.
All right. So let's see here. Anybody else want to volunteer? Okay, let's see. Dr. Ganti.
Hi, can you hear me?
Yep, I sure can. How you doing?
I'm well, thank you for asking. How are you?
I am good. And are you a generalist?
Yes.
All right, let me get your case. So your dealer's choice. Tell me what case list or case you'd like to do.
I think office.
Okay. All right, so let me pull something up from here. And let me kind of scroll toward the back. It's so easy for us when we do these to stop at the front and everybody forgets about what's in the back. Let's see. This is just going to be a quick one, but I think it's a good one to review. So you have a 36-year-old G0P0 who presents with secondary dysmenorrhea and abnormal bleeding. Her physical exam was normal. Her ultrasound said suspected adenomyosis. What is it showing on ultrasound that would tell you that?
On ultrasound for adenomyosis, generally the uterus is larger, more, I don't know if globular is the right word, but
It is.
generally larger, globular, has a sort of a cystic appearance, can have more vascularity, heterogeneous myometrium. Sometimes there's striations from the endometrium into the myometrium.
Okay, and so when somebody comes in with abnormal bleeding, do you typically get any labs on these patients?
I do. Usually, I mean, some of it's based on the history, but I generally have to get a thyroid testing, prolactin. I usually have to check a CBC or some kind of like hemoglobin check to check for anemia. And then I also you said laboratory testing. That would be like the bare minimum. And then again, depending on the where I'm thinking the differential is leaning toward for the AUB, I might, or the abnormal uterine bleeding, I might order additional testing.
Okay, yeah, so anyway, so the 36-year-old, she comes in with cramps and abnormal bleeding. So just go ahead and quickly walk through what your differential diagnosis was.
So this patient came in with regular cycle, but heavy menstrual bleeding lasting more than 7 days, and was having a symptomatic anemia as well as debilitating cramping. And so my differential was kind of walking through the palm coin algorithm for abnormal uterine bleeding. So uterine etiologies such as adenomyosis, which is seen there, fibroids or leiomyomata rather, polyps, rarely malignancy, as well as ovulatory dysfunction or like intrinsic endometrial dysfunction. And then if all of those have been, and then as well as like a systemic issue, like hematologic bleeding dyscrasia, like a coagulopathy.
Okay, so she actually, when you did her CBC, she actually was anemic, correct?
She was anemic, yes.
Okay, so then tell me how you managed her anemia.
This patient had not been doing anything for her anemia, and it wasn't severe anemia. I believe her hemoglobin was around 10.9, and so she I counseled her about oral iron supplementation, and then primarily we discussed some kind of treatment plan that would lead to ideally amenorrhea. So that's why we chose the levonorgestrel intrauterine system, and then that as a combination on her repeat hemoglobin check, it had significantly improved.
Okay, yeah, so the levonorgestrel IUD was a great choice for her. Tell me how you counsel her, though, initially of what she may expect menses-wise with the levonorgestrel IUD.
I always counsel patients that the intrauterine system, the levonorgestrel intrauterine system, generally can cause irregular bleeding, and anywhere from spotting to sometimes filling up a pad, which can be disconcerting for patients, and sometimes that can last anywhere from 3 to 6 months, but generally tends to settle itself into its whatever pattern it's going to be after that. And I also counsel them, if they're not expecting it, that they may become amenorrheic. I suppose it's possible to have heavier periods, but I generally don't see that in my experience.
Okay, and so now with regards to on physical exam, I know you said it was normal, but if you were doing a pelvic exam, what can you typically feel or what seems different when you're doing an exam and the patient actually has adenomyosis?
Generally, for adenomyosis, I find that the uterus is larger, and I suppose it's possible that the uterus could also be more tender on bimanual exam, but generally it's at minimum it feels like a larger uterus.
100% I agree with you. It's larger, it's like you say, kind of globular. Oftentimes my patients, their uterus is more tender. It absolutely is. So good. So let's pretend this patient was 46, a G6P5, and had a tubal ligation, and you thought she had adenomyosis. Tell me why she would be a poor candidate for an endometrial ablation.
A patient that is 46 with abnormal uterine bleeding, I would be concerned for making sure there isn't an underlying malignancy, and I wouldn't want to perform an ablation and seal in that kind of pathology, so to speak. Not to mention, moving forward, she would have an elevated risk just by age, and so I would be concerned about making it harder for sampling in the future, or impossible for sampling in the future.
Okay, but what about adenomyosis itself that
Oh,
makes
great question. Sorry. So yes, I think I know what you're asking. So I also wouldn't recommend an ablation in this circumstance because I don't think it would treat the underlying pathology. So the patient would potentially have improvement with bleeding, but certainly I don't think that the pain would be improved at all. In fact, it could potentially worsen with post-ablation syndrome.
Absolutely, and that's exactly what I was getting at. So that's why somebody who has a significant pain component to their bleeding is not really a great candidate for an ablation, primarily because they probably have an adenomyosis component to it. So good, that was excellent. So I guess, do you have any questions for me?
No, I think that was really helpful. Thank you so much.
Thank you. All right, you guys, we should have time for one more volunteer. Come on, you guys, I'm the nice one. If you're going to volunteer, this is a good time to do it. Okay, how about any of the people that have already gone today? Anybody want to go again? Oh, there's Christine. All right, let's get her in. Hey, Christine, thank you for volunteering.
Hi, sorry, I was seeing a patient earlier. I would have done it sooner.
Okay, well, good, because I was like, nobody wanted to volunteer. I guess I must seem mean. So anyway, so are you a subspecialist?
Yeah, I'm a GYN oncologist.
Okay, got ya. All right, so both of your case lists. Where's your OB case list? You don't want to put it up there. I'm kidding. I'm kidding. So what do you want to do? GYN or office? Are all your... Okay. probably almost all your GYNs are cancer related, right?
I have a couple that are endometriosis, I think.
Well, here's a leiomyoma. Let's do this one. Okay, let's say here you have a 48. This is patient number 6, a 48-year-old G1P1 who came to you with basically bulk symptoms due to leiomyoma. Did she have any abnormal uterine bleeding associated with that?
So she had been experiencing, I believe, heavy menses prior to that. It had been that way her entire life. And she had
Okay.
previously been on birth control pills.
All right, so let's say your 48-year-old comes in, abnormal uterine bleeding / heavy menstrual bleeding, and kind of bulk abdominal pressure and pain type symptoms. So we've already walked through the differential diagnosis with Amitha, and she did a nice job with that of the Palm-Cohen. But tell me, when this patient would have first presented to your office, how you would have evaluated and worked her up.
So when this patient first presented to the office with abnormal uterine bleeding that was heavy, I first would have done a thorough history and physical exam, asked her about her past periods, what the onset was, the duration, how many pads she goes through, if it's impacting her ability to have, her day-to-day life. And I would do a physical exam consisting of a pelvic examination. I would ask her when her last pap smear was, if I had to continue with her screening paps if she was due for one. I would do a bimanual exam. And in this particular patient, I would have felt the uterus up above the umbilicus. I also would have performed a rectal examination to see if there is mass effect on the rectum due to the large pelvic mass. Following my physical exam, I would have ordered imaging studies. Given the size of this uterus, I would have started with a CT scan as opposed to a transvaginal ultrasound, just because it would not have been able to fit the entire uterus in the field in order to get an accurate understanding of the size. And as she is 48, I would have discussed with her at that time an endometrial biopsy for abnormal uterine bleeding over the age of 45.
Okay, so let's say her endometrial biopsy came back benign. She had, let's make her a hemoglobin of 10, and you do confirm this large leiomyomatous uterus. She's 48 G1P1. Fertility's not an issue anymore, so you discuss with her her options. So with the option that would be definitive, of course, would be to proceed with a hysterectomy. So tell me, once you guys decided on that, what type of an abdominal incision did you make with this large of a uterus?
I made a vertical midline incision.
Okay, all right. And so then you remove her uterus, get rid of the tubes. So now tell me, what are you going to do to try to minimize her risk of postoperative DVT? So you've got a 48-year-old that you did an abdominal procedure on.
So postoperatively, I do the Caprini score to see whether they need, in addition to their early ambulation and STDs while they are in bed, whether they need either Lovenox or heparin. And based off of their score, I either continue it in the hospital, or if they score high enough, I give them a course outpatient as well.
Okay, and so you're going to have the sequential compression devices on prior to induction of anesthesia, throughout the surgery, and post-operatively while they're in bed. You're going to do early ambulation and use the Caprini score to determine if they are candidates for post-op Lovenox. Okay, great. What would you do if this patient was 33 G0P0 with this huge leiomyoma? What could you have offered her?
So if she was 33 and desired to maintain fertility with her uterus, I would have discussed with her a myomectomy. When I approach myomectomies, I typically will, in preparation for the operating room, will order an MRI to better delineate the location of the fibroid, so I can have a better discussion about the risks of success versus failure in terms of size, location, and number of fibroids before going to the OR.
All right, and then when you do a myomectomy, you know, one of the risks, of course, is excessive bleeding. Tell me what you're going to do to try to minimize the risk of blood loss.
So when I perform a myomectomy, I will inject pertussin or vasopressin. I use a solution of 20 to 200 in normal saline to decrease the amount of bleeding that I have at time. I'm very meticulous with my dissection to try and make sure that I'm actively managing any bleeding that I might get into in terms of on the serosa or in the myometrium. While I'm holding pressure, I use things such as quick clot if I need to, in addition to pressure, to try and maintain hemostasis as I'm performing the procedure.
Okay, so then this leiomyoma was huge, so you obviously had a pretty large defect that you had to repair. How long after you've done this repair in our 33-year-old who desired conception, how long would you recommend she wait to attempt conception to allow that myometrium to adequately heal?
So, and if I was removing a large fibroid that I did breach the endometrial cavity, I would, close it in 3 layers, similar to like a classical cesarean, and I would give her the same precautions that I would from a cesarean section, the classical, to wait 18 months.
Okay. Let's see, what else would I ask? What if this patient, this 48-year-old, truly, could you offer her any other options besides surgery to remove the uterus? Are there any other procedures that could possibly help her with her AUB and maybe her mass effect?
So we could have considered a trial on depo-lupron to see if the estrogenic effect could have decreased the size. That would have taken, quite some time, and because this fibroid was so large, to see a significant effect. I do know that there are some ablative techniques that people are using as well. That is not a technique that I'm comfortable performing, but there is an option.
What about uterine artery embolization?
That could also be considered in this patient, as she was 48 and was not pursuing any fertility.
Yeah, okay, good. Yeah, so anyway, there's a practice, but reason I'm bringing it up, there was a practice bulletins, one of the few up-to-date recent GYN ones that have to do with GYN topics. So the two that ACOG published probably in the last 12 to 18 months that have to do with GYN, one is the prevention and management of postoperative DVTs, and the other one is management options for symptomatic leiomyoma. And so because most hysterectomies for benign disease have myomas involved or one of the main causes for it, that would be a good practice bulletin to review. And it talks about, myomectomies, uterine artery embolization, the new cryotherapy things. That's what you're talking about, Christine. I actually had one candidate who they were actually doing it, and she said it's actually pretty cool. I also do not have experience with that, but she said what was pretty neat is when they go in and they cryo the individual myomas, not only does it help, I'm going to almost call it like disintegration of the myoma, but they don't hardly get any pain because the cryo destroys the nerves feeding to it also. I was like, oh, that's cool. Whereas, you know, with uterine artery embolization, there can be some significant pain component. But anyway, it kind of reviews that. It reviews the medical therapy. There's now that new, what's it called, MyFembry, where you can do the GnRH antagonist plus some add-back therapy to treat myomas. So it would just be a good review to know the different options with that. And then, of course, we talked about the DVT. So good job. And you did the right type of incision, which I would expect nothing less from a GYN oncologist.
I do occasionally do a fan and steel. I did them on my
just giving you a hard time. All right. Thank you so much for volunteering.
Thank you.
Any questions for me?
No, I mean, I know one of the things I know I'm going to have a hard time defending on my case list is that I do a lot of hysterectomies at time of adenexal masses because I do shared decision making, and I have a lot of older patients who say, go ahead and get everything out. Any advice on how to defend those?
Could you give me, do you have an example somewhere?
I know I have a 40-year-old that she had an 11-centimeter mass, and I did an abdominal hysterectomy on. She had started having a little bit of dysfunctional bleeding. At the time, I thought it was going to be a borderline when I sent it for frozen, and her and I had discussed whether or not she wanted to maintain fertility or proceed with a hysterectomy at time of removing the mass.
And did her uterus come back like totally normal?
It did. She had some scar tissue on it, and her mass ended up being a teratoma. She had an elevated CEA. It looked abnormal to me on imaging, hence why she was in my office. But
yeah. So anyway, so here's what I would do. If I was just wondering if I could actually find her, but you have 22 darn pages worth of stuff.
I'm so
yeah,
sorry.
So I'm teasing. So let's just say you had somebody with the adnexal mass, and then she had some degree of abnormal uterine bleeding. And so that I would do, again, with the shared decision making, you discuss the fact that this mass, this was your differential diagnosis, that there was a concern that it could be if it was a borderline, then wouldn't you take out both ovaries?
And I was going to take out the additional ovary when the frozen came back if it was borderline.
Okay, got you. I got you. So I think probably the best way to do it would be to say, make her have something, some cramps and a little bit of abnormal bleeding, and that through shared decision making that you've decided that at the time of surgery that you would also proceed with hysterectomy because of the either dysmenorrhea or the abnormal uterine bleeding, something like that. Because otherwise,
and that's what happened. So
yeah,
she was weird bleeding.
That's totally. Because there's a lot of candidates, you don't see them because you're not reviewing the case list, that it's abnormal uterine bleeding, failed medical therapy, and they do a hysterectomy and there's no uterine pathology. So I don't worry about that. As long as you feel that you discussed with the patient, she had some symptoms and she's like, we're going in and I'm done and I'm not taking any more hormones and I hate the side effects, etc.
Okay.
Does that make sense? Okay, good. All right, great question. All right, thanks, Christine.
Thank you.
Okay, so that ends tonight. Let me see here. Okay, guys, so thanks so much, and I'll be back, I think, next week sometime.